Hi, everyone. Thank you so much for having me today. I am excited to talk a little bit about some of my research interests and my program of research. I am a pediatric psychologist and assistant research scientist in the Center for Healthcare Delivery at Nemours. Um, Being a psychologist, my area is largely in behavioral health. And today I want to share a little bit about kind of a up and coming and newer area of research in psychology called single session interventions. So, most of my research interests really lie at the intersection of physical and mental health. And unfortunately, we are facing a growing mental health crisis in the US. Being in, pediatrics, I'm obviously focused on children and adolescents, but this is pretty much true across the lifespan. Um, and one of the big challenges that we face is that we have quite a few evidence-based interventions that can address a variety of presenting issues. Um, but the biggest challenge is that a lot of these manualized interventions span 12, 16, 20 plus sessions, and this can take months to years for us to get through. Um, and unfortunately, not everyone has that availability to get through these really large interventions. The other challenge is that we just don't have, the mental health resources that we need to keep up with the demand. There are just not enough mental health providers. And then on top of that, families also encounter a lot of their own individual and systemic barriers as well. Like I said, not everyone can make it to all of those different sessions, especially if they're weekly or every other week. Insurance is always an ongoing issue for some families. And even though telehealth is definitely opens up a lot of access, um, telehealth's not always a great fit for everyone. And so one of the things that, we've been thinking about, I think, in the field is how can we really um, make our treatments scalable, feasible, and more targeted? Largely because on average, youth really make it to about 3 to 4 therapy sessions. And the challenge with that is our first session is always an intake, so we're getting background information, we're talking about your treatment goals, and then working with kids, you need to build some rapport. So maybe your next session or two is building rapport. So we're not actually getting through a lot of the intervention itself. And then I think kind of something that's very sobering for a lot of psychologists to think about is the fact that the modal number of session attendance across everyone, children, adults, older individuals, is actually one session. Um, and so when we think about that, we really need to be mindful about how we're utilizing our time. And so single session interventions is something that I've become really interested in recently. And these are highly structured and targeted interventions that involve only one encounter with either a clinic, a provider, a program. And these have largely been developed in the general population. So this hasn't been something that has been highly utilized in pediatrics. But we've seen some really promising results when it comes to treating depression, anxiety, externalizing behavior. And what kind of underlies these interventions is that they really span multiple theoretical orientations. So it's not so much just here's a CBT, single session intervention, but rather here is something that is taking a core mechanism that underlies quite a few different manualized interventions that is kind of the key driver in behavior change. And so this is something that I'm hoping to really utilize more in a pediatric context, particularly with individuals where, mental health is starting to impede physical health and well-being. I do just want to give a disclaimer because I think something that comes up a lot is this idea of, okay, but a single session intervention might not be enough. And I agree. I think a single session might not be enough for everyone. And so these are not intended to replace traditional outpatient mental health care, but rather the goal is to have multiple types of treatments that can coexist together to meet the needs of our current demands. Again, this mental health crisis it's a mountain of an issue. And so having diverse options available that will help broaden and expand our treatment approaches can hopefully help give us a little bit of traction in tackling this large scale problem. And so I always just like to throw that out there, that this is not meant to replace outpatient mental health care, but rather is a supplement. Particularly helpful maybe for individuals who are on a wait list. Wait lists are months long now at this point. So maybe there are some individuals that just need something until they can access a therapist on a regular basis, or someone who's having subclinical concerns or symptoms, and maybe they don't need a full course of CBT, but maybe they just need a little something. I always like to say something's better than nothing, and right now, most people are getting nothing. So the area that I work in is pediatric diabetes. And so most of the kiddos that I see, both clinically in diabetes clinic and then also for outpatient therapy, are struggling with some aspect of either engaging with their, treatment regimen, or, adjustment to the disorder, or just the distress that can come with managing a chronic illness. And so I'll just give some very quick background on type 1, but type 1 is a common pediatric medical condition. It involves a complex daily regimen where you're, pretty much all day, every day, monitoring and regulating your glucose levels, you're administering insulin, you're tracking your carb intake, and hopefully engaging in some physical activity to help regulate some of your glucose levels. Unfortunately, what we see in youth is that most youth are struggling to kind of manage their type 1 effectively. And so we typically use hemoglobin A1C as a marker for how individuals are managing their type 1 through this assessment of glycemic control. And as you can see here on this graph, both of these colored lines indicate different cohorts. In that 10 to 20 age group, we see a huge spike in A1C levels. This solid blue line indicates the previous recommended A1C number, 7.5. This dotted line now is now the recommended number of 7%. So as you can see, kids and adolescents have kind of a long way to go in terms of meeting those recommendations. And this is problematic because it increased the risk for acute and long-term complications. But what's really interesting and exciting for me is that, there's such a large behavioral component to managing type 1, and we have a lot of opportunities for intervention. So much so that it is overwhelming. There are so many different intervention targets that we could um, uh, potentially utilize in an intervention, right? Anything from family conflict, family support, peer support, school environment, executive functioning, internalizing symptoms. All of these things could be options. But the area that I am focusing on is depression. That is the really clinically significant target for me. And the reason for that is because up to a third of youth are reporting elevated depressive symptoms. And this is much higher than what we're seeing in community samples of children and adolescents. And the reason why we're concerned about depressive symptoms is we have really good evidence that shows us that youth and adolescents that are expressing higher depressive symptoms are also experiencing more hospital admissions. They're more likely to have higher A1C values. They might not be getting as much insulin as they need throughout the day. And we see reduced glucose monitoring. Now, again, the good news is we have really good evidence-based strategies to target depressive symptoms. But unfortunately, kind of going back to some of those challenges that I mentioned, we have limited mental health staffing in diabetes clinics. We have limited mental health staffing kind of everywhere, but particularly in diabetes clinics. So that's a huge challenge. And then, unfortunately, of the youth that have type 1 that are referred to outpatient mental health care, less than a quarter make it to that appointment. And then of those that do make it to appointment, half only attend one session. So we have a really small window of opportunity here to try to move the needle on some of these symptoms. And so this is what really inspired me to write a K-23. And so last year my K-23 was funded, and I've now just started year 2, where the goal is to develop a brief and scalable depression intervention, single session intervention for youth with type 1 to improve mood and hopefully some health outcomes. So I'm just going to very quickly kind of walk through what my plan is. The first thing that I did was I created a youth advisory board where I partnered with adolescents with type 1, really to get their perspective during this early intervention development. We have interventions that we can utilize, so I'm not recreating the wheel here. I'm adapting an intervention that has already provided evidence for efficacy. However, I want to make sure that my adaptations are ones that are important to youth with type 1, and things that they, that make sense to them and that they feel like are important changes to make. So I've been holding separate meetings with younger teens and older teens. And really the idea is just to get feedback from them on, how we're adapting the intervention, when they want this intervention. Do they want this intervention in clinic? Do they want it outside of clinic, in person, via telehealth? And really to make sure we're incorporating any content that is relevant to them in the way that feels, just authentic and, again, important to them. So right now we're in the midst of our qualitative interview. So to adapt the intervention, I've been interviewing adolescents with type 1. I'll also be interviewing some diabetes providers. And so during this time, we've been walking through the different components of the intervention, which provides some psychoeducation. We have like a values assessment to identify key areas of enjoyment and meaning. And then we put together an activity plan that really targets specific areas of behavior change for kind of for like a behavioral activation type of intervention. And so this is necessary to do because I want to make sure that I'm separating any like somatic depressive symptoms. So depression can impact a lot of different areas like concentration, fatigue, appetite, weight, sleep disturbances. Those same things happen sometimes for individuals with type 1. So there's a lot of overlapping symptoms, and we want to make sure that we're being mindful about how we are targeting each of those. And then we also want to make sure that we're incorporating anything related to like diabetes distress or struggles with treatment engagement that will be more salient for teens with type 1. Once we are finished adapting the intervention, we're going to do a pilot RCT, really to evaluate the feasibility and acceptability of this intervention. So our plan is to recruit 80 youth and randomize them either to this type 1 specific single session intervention or a control group. My plan is to collect a lot of data. So we're going to have quite a number of self-report data. I'm also going to get some ecological momentary assessment data, which is going to give me a daily self-report assessment on their affect and mood before and after the intervention to assess intrapersonal differences in those kind of in those assessments. And then we'll assess all of these different self-report measures and their A1C levels about 3 months after they've had the intervention. And then I've added a 6-month assessment as well. While we're doing the pilot RCT, we'll also be interviewing youth who've received the intervention, their parents, and additional diabetes providers. The idea for this is we want to make sure that we're identifying any barriers or facilitators to this intervention while we're still kind of in this early stage. And the reason for that is, I want to be thinking about implementation now at the beginning versus having this intervention and thinking about implementation down the road. And so if there are any changes that we can make early on in this, kind of earlier intervention stage, then we might be able to change some things that could later impede implementation in a clinical setting. Um, so that was a quickened, very kind of quick high overview of my program of research and my current grant that I am working on. But I'm really excited to, share the things that I'm excited about with you. And if there's anything that you'd like to chat about or questions that you have, happy to talk about that further.